Good afternoon, everyone. Thank you so much for coming. I'm very pleased to introduce Meaghan, who has recently joined UNICEF. She's here from the Global Innovation Center. She's the Global mHealth Product Manager. She's based in Nairobi, so we're really excited to have her on board. Prior to joining UNICEF, Meaghan worked at Medic Mobile for the last 3 years, where she was the regional director for Africa and worked on mHealth implementation for about 30 programs, I think in 11 different countries. And we're also very pleased to have Kidus join us as well from the Global Innovation Center. He'll be joining us remotely. And they'll be presenting on the 1,000 Days Toolkit, which is being developed within RapidPro. And this is really being kicked off, so we really wanted to use this as an opportunity to have a quick presentation, a demo, and have a lively discussion so that we could get input from everyone here and learn more about the roadmap and ways that we can work more collaboratively with the Global Innovation Center. So if it's okay, can we just have a very quick round of introduction so we have a sense of who's in the room? And I'll let Maureen start, please.
I'm Maureen. I work with the knowledge management team for the health section. I'm Deborah Jackson. I'm also health section, knowledge management implementation research. There's some more seeing here.
Hey, I'm Pilar. I work in the communications team and innovation unit, so I'm a colleague of Kidus.
I am Teresa Diaz. I'm the Chief of Knowledge Management Implementation Research Unit in the Health section.
And I work in the medical unit in the nutrition section.
I'm the landscape and density section, and I work, among other things, on care for child development, which is basically the most of the healthcare system globally.
Good afternoon, I'm Pablo Sansbury. I'm the Early Childhood Development Advisor in the South, but also in Nairobi.
Yeah, very cool.
I'm only here for heaven's sakes. Awesome. I know about internet.org, so I'm kind of mixing it up with different pieces together.
Lined up. Okay, great.
Afternoon, my name is Richard Dunn. I work in the health section.
Hello, I'm Marina. I work in Polio Research and Implementation.
My name is Sarah Rossman. I'm a consultant in the nutrition section.
Hi, I'm Brooke Situma from the nutrition section.
Yeah, hi, I'm Ashid Ahmed. I'm working as a program specialist in MNH health section.
I'm Deacon. I'm in charge of tuberculosis in the child health team, and we actually once met a year ago in our old jobs when I was with the International Union Against TB, and we used to work in the room.
Yeah. Very small room. We're just doing introductions.
Okay. Hi, my name is Mariko Anzalacorda. I work for HIV section. I'm working on knowledge and innovation.
I'm Dimitri. I'm Dimitri Davidov from the immunization unit.
Cool. David, you want to quickly introduce yourself? Just brief introduction.
Latecomer to punishment.
My name is David Craig. I'm a senior health specialist in the knowledge management section.
Okay, cool. And I'm Maria Muniz from Health Section Knowledge Management. And then we have a couple of colleagues, Ian Thorpe and Dana from Innovations, that's joining us on Skype for Business. And perhaps it's also a good time to have Kidus introduce himself briefly, make sure that we can hear you.
Wonderful. Can you guys hear me?
Yeah.
Yes.
Hi, everyone. I'm Kidus Asfam, the Global Product Manager for the Innovation Center, primarily supporting the development and rollout of RapidPro, which is an open source platform that UNICEF uses in over 30 countries now to do a variety of real-time monitoring work around health, education, communications, and a variety of other applications there.
Let's dive in, and then we're actually going to do just a really brief presentation, and then we're going to move into a live demo. So I hope that everyone has brought their mobile phones. It looks like we're covered. Cool. So first of all, thanks to Maureen and to Maria for organizing and for inviting us. Kidus and I have just been working together for the past 3 weeks, so I'm really, really new blood. I've also never worked with UNICEF or the UN before, so I have no idea around the bureaucracies and the challenges, but I think that actually brings quite a good, fresh feel to the space. I've worked in the social entrepreneurship sector for the past 5 years and focused very specifically on health, but with a business background. So I have a real perspective to figure out the economics behind these costs in these new systems, but also to think quite closely about the factors that affect how people make changes in their lives, why they would begin to use a different phone, or why they would walk a mile to a clinic instead of make a phone call, asking those tough questions. Yeah, so initially, I think a lot of you know who we are, but the innovation team at UNICEF, we're based out of, oh gosh, we have 5 people that work remotely, and then we have hubs in San Francisco and New York and Bangkok. But we also have seconded staff members that work within offices and lead on innovation. Seconded might not be the right word, but basically experts who are alongside of deployments or alongside country offices that are very much focused on innovation. And if anyone wants to know more about how that fits with your programs, feel free to let me know. So the remit and what we exist for is to do something different that adds concrete value. At the end of the day, my remit is to bring evidence to the table that helps you and your colleagues to make decisions to change the way that you deliver programs. That is based on the principles that have been adapted by a number of large global donors, WHO and ourselves. And these are basically the way that we think about every single problem. So we look first at designing with the user. That's a fancy way of saying, do you actually ask questions before you deploy or before you build a system? The second is to build with local brains. Something like a mobile phone. I was in Congo last year at the beginning of the onset of the Ebola outbreak that they dealt with. And I brought this mobile phone and 4 other mobile phones to choose, to basically select devices from. And I asked our Congolese community health workers what this was. They said it was a television. So to them, they see a very modern smartphone as something that should be stuck on a wall. They're never going to take it into a community. They're never going to get it dirty. They're going to be worried about what happens when it rains. And this is probably not the most appropriate device. So thinking about asking those users questions, leveraging what's inside of their brain, and using that as part of your workflow is how we think is the best way to operate. Designing for scale. This one's hard because you can't possibly understand the challenges that are going to come, but to think big initially. And that's usually in regards to the type of infrastructure that you set up. You wouldn't build a road that didn't have the proper foundation. So we look at scale as a foundational issue and an architectural issue. And my role is helping to build frameworks that can guide you and your teams to build better systems that will last, but also that can be supported beyond the initial 1 site or 2 site deployments. Building for sustainability, that has to do with local capacity, that has to do with policy frameworks. It's probably the least exciting and dynamic part of my work, but it's by far the most critical. Because if you don't look at those questions early on, then you can miss a lot of what needs to happen. Being data driven. So there's a lot of information, some good, some bad, and facing that data early on as opposed to waiting for your annual program review is just basic good practices. Open standards, open data, and open source. These are all technical words that mean very little, but basically what it means is you build something that can be shared. Open source software is software that doesn't have a licensing fee, but more importantly, software that can be shared. So if you build an innovation for Nepal, that can then be rolled out in the Philippines without additional costs and can be built upon for Nigeria. And as UNICEF, we should be thinking through the way that those opportunities can really be enhanced so that you're not spending $200,000 of your budget on a custom software deployment. And you'd be amazed. I was speaking with the CHI Global mHealth lead. CHI as a company has built 90 products. Can you believe that? 90 apps, 90 vaccine trackers, 90 distinctive products, spending hundreds and hundreds of thousands of dollars on that. And it's a wasteful practice, but it's also very confusing for the end user. When I think of a community health worker, I think of my mom. She's 65 years old. She lives on a farm in South Dakota, and if you give her 2 apps to use, she's done. She wants 1. Reuse and improve. So that's when you have open standards and open data and open source, you can reuse that. If you don't, you'll get charged for it. I was also on a project where a company from India built a custom database for a partner, and they ended up holding their data hostage. So at the end of the project, they charged the project $10,000 to access their data, not even to do anything with it, just to be able to export it. And those are horror stories that you can just imagine sitting at the end of your grant, being ready for that final report, and them saying to you, give us $10,000 or you can't write your report. But ransomware, that sort of practice it's happening more and more. And so being aware of the fact that you need to plan for that is something that I can be a support with, and also Caduce can be a support with practically to help to protect country offices, but then also ministries for building those systems that can be accessed at a later stage. Do no harm. It seems like it's impossible to do harm with data, but on a health workforce level, patient data is incredibly valuable, and the way that data is managed needs to be respectful, even if the users that we're engaging with are not aware of their rights. It's my belief that UNICEF will likely lead in this area, and so thinking now and thinking very deeply about the way to protect the rights of our patients that we're collecting information on should be one of those discussions that's happening on a regular basis. And if there is an issue, just to face it head on and then to build better next time. And then finally, to be collaborative. So what does scale look like? I'm going to talk through just a use case of use case is a technical word for what might be a program. So it's basically a bundling of software functionality and human interactions and an outcome or some sort of activity. And then that is taken as a single module. So I'll keep using that term. I'll challenge you to use that term. It's a really good one to put into your vocabulary. You sound smarter. And it's one that you'll hear a lot in this sector. I know that there's a lot of terminology and jargon that's useless, but I'm going to try to drop a few in there so we can start to sound really smart. So the challenge that was brought to us by the Ministry of Health and the UNICEF Country Office of Zambia was that the HIV results were detrimentally slow. So there was an engagement process with the ministry, and a project was assigned that's called Project Wana. The eventual goal, I'm going to go into this workflow in greater detail at a later stage, was to increase the feedback, to reduce the feedback time and increase the quality of results that were coming to mothers to test both themselves and their children around their HIV status. At the end of the day, we ended up reducing the paper-based form time from 66 days to 34 days, and we've begun to look at scaling that system in Tanzania as well. The Ministry of Health there was very excited. There's still some design issues that we have to work through as we're building for scale around the confidentiality of patient data. But that's also brought us into thinking about innovation around maternal and neonatal child health in a different way. So the way that we're approaching innovation as the UNICEF team is focusing on what we're calling the 1,000 Days Toolkit. We say RapidPro, which I'm going to demo to you just now, but this could also be any type of tool or system. It's just that we're looking specifically at the types of engagement and continuum of care that women and children have within the 1,000 days from conception to the child's second birthday. So you'll see under there, it's time-based, and then each of these little marks underneath of each of these little points are actually what I would call functional use cases. So something very basic, antenatal care reminders. Everyone here can see that I'm very pregnant. If I was to be enrolled in this program, the use case or the engagement that I would have would be reminders to go to my appointment, confirmation that I've gone to that appointment, clinical updates from the nurse or physician to let the back-end system know how I'm doing, and then potentially danger sign monitoring. So it's one system, it's linked to one person around one continuum of care, but from there then you can branch it off into a number of different opportunities to engage with that mother. You can build emergency services off of that once you have that information. You can build immunization reminders, postnatal care reminders. I'm looking at the antenatal care point as sort of the crux of a lot of those engagements, but I'd love to have conversations with each of you in your functional areas around the opportunities that you would see for these types of systems. So how can we collaborate? I just had a really great conversation with Dimitri around the work that's happening within within immunization and demand and supply. In the next few months, I'm going to be building out just an overview of exactly what's happening where. If nothing is happening, that's okay. I think that there at the moment is a great need just for our teammates to know who is working on what, how it's working, what's working, and what could be improved. So that's basically figuring out what is possible and then grounding yourself and your program within that. If you want to do something new, this is the space where we can also be having conversations. So if you were sitting here with a $200 billion proposal and someone said to you, oh, and I've heard this question, I think we need an mHealth. That's not enough information. The first piece that you have to actually do is identify your use case. I'm working to build resources so that you can do that yourself, workflows and kind of interactive. They're largely case studies that you can start to ground yourself in. The next is to decide on who your system users are going to be. So going back to the Project WANA example, you can see that this isn't just a one-person system. So you might think initially that your user is the pregnant mother. But in order to actually get all of the information that you need, you cannot just stop at the pregnant mother. You also need to look who else is engaged. It's her husband and potentially other family members. It might be a mother-in-law. So those two then are both users that you need to understand. And for each user that you identify within your system, you need to build something that's called a persona. And I'm getting a little bit deep here, but it's worth just making you aware that it's not just saying, I'm going to send an SMS. That's not enough. Understanding your users is the first step to actually building a system and a module of engagement that's going to have long-term effects. And then from there, you have to know your clinic worker. You have to know when they wake up, when they sleep, what type of phone they have, how much money they have, if they're comfortable sending SMS. You also need to be linked into the lab here. And then you have to understand that all of this is driven by a mobile network operator. So you also want to know something about the mobile network infrastructure. So that's a really, what would seem like a very simple system. All you're doing is sending a test result. But within that, you have 5 to 10 personas that you need to build out. And I would argue that you should actually meet and talk to each of those users. Within a persona, you want to understand the values of those users. You want to understand the characteristics of them. And you want to be able to pick them out of a room. So if I were in marketing and I worked for Samsung, I could look around this room and each and every one of you is a consumer persona. So you buy a certain way, you spend a certain way, you plan your future in a certain way, and that drives the product that I build for you. And if you're brave enough to move into the innovation sector and to start to engage technology, you become a consumer marketer. So you actually start to build into the value statements that drive the decisions behind your end users. And you have a lot of fun. It's actually incredibly amazing work because all of this behavior understanding links then to your programmatic outcomes. And you can begin to speak to the value set of that mother and that father and put them at ease. And what's even more interesting is to think about the additional way that you could leverage that connection. So this is a very basic system, but once that infrastructure is in place, you can use it for vaccine reminders. You can use it for Ebola outbreak notifications. It becomes a piece of infrastructure, just like a road, that then connects you to all of your end users and allows you to engage with them in a very dynamic way. But what's more, it also allows you to build trust and a relationship with those end users. And if anyone has spent time in different parts of Africa or South Asia, you know that trust is the foundation of a lot of health decisions. And so I also see this infrastructure as an incredible opportunity to build that dialogue and to learn more than we could have ever learned before when we were waiting to build, to collect a focus group under a tree somewhere. The next, determine your impact metrics. So impact is a buzzword, I'm very sorry. But impact is basically just measuring the evidence that something has changed. A lot of partners start with that. So you look at your log frame and you say, okay, I want to measure the number of live births. And you build a system that's going to measure the number of live births. I've inverted that very much on purpose. If you start with your impact metrics, you're going to miss the personas because you'll be trying to tell someone to go. We've all told mothers to go to a clinic. I've been told to go to a clinic. There's certain parts of my health decisions that just don't change. So understanding those values has to come before you say, I want you to do 1, 2, 3, 4. And then design, deploy, redesign, and deploy. Deploy is putting a system out there. And this is what we call iteration and not failure. So if anyone in this room were to deploy an innovative M or E health system and only send out one version, my bet would be that you ran out of money and that you didn't plan properly. You should plan to launch a system once, do testing, find out, try it again, do testing, find out. We're moving away from the programmatic environment where you need to decide on something in year 1 and continue to do that in year 10. You know, the innovators that built on SMS, they're poor. The ones that built on Android, they're really, really rich. And we're now in that same environment where devices and technology are moving literally at the speed of light, and we get to begin to innovate in that very aggressive innovation space that's global. And then our demo. So now I'm going to hand it over to Caduce. This is where you get to get out your phones and not feel ashamed that you're not paying attention. Caduce, are you there? And if he's not, then we can do it together too.
Hey everyone, can you hear me?
Yes.
Okay, for some reason I was breaking up, so great that you guys texted. So Meaghan, do you mind just repeating the last piece of what you had mentioned?
The last piece that I mentioned was that we were going to do a live demo. Did you want something before that?
No, that's fantastic. So I don't know if you've been able to log on to RapidPro, and if not, that's fine. Essentially, as Meaghan has been speaking through all of these different use cases. What we've been designing is a common platform, obviously open source, that can make it really easy for you to interact with your end user. Your end user being a person, in most cases, with a mobile phone. And what this really does is it takes away the idea of having to build software to actually designing interactions with people. So what we're going to do is we're just going to go through a very, very simple demo here where we're going to have you introduce yourselves to RapidPro and also give us insight into how great Meaghan's presentation was. Okay, so I don't know if Meaghan has the phone number up on the slide. I believe it is.
Yep.
917. Oh, great. All right. So all you're going to do is you're going to text the word health to 917-720-2007. And we'll probably just give you 2 minutes to experience how that interaction goes. And then we'll follow up on that.
I did it on purpose. I just need to open it up.
Okay. I'm gonna.
You may experience troubles, technical difficulties.
and just let me know if there's any issues. Not sure if I have everyone on the line still.
Yeah, we're just here. We're back. Yes.
All right, fantastic. So how many people successfully talked to RapidPro?
Oh, and it runs you back.
Yeah, you want to look.
See, this is user design. This is why you do things twice. Just tell them you're in your home section. Just make something up. Okay.
Sorry, I didn't catch that.
Basically, people are answering health, and then they're going back to the beginning of the flow.
Hello, what's your name? Yeah.
Ah, interesting. Well, this quickly actually demonstrates how important it is that you spend more time designing your questions than just thinking that the tool will do everything for you. Yeah. We actually built this in 2 minutes. Yeah. I'm not sure if there were enough people that actually went through it, though. So did anyone successfully complete the questionnaire?
I did. Yeah, it took me to the greater here. Let us know how we can help you in your work. And since it's not a question, I assume the conversation with Siri is over.
Okay, so didn't ask for your name, where you work?
It did. It took me all the way.
Oh, great.
Everything is fine, and then it was satisfied.
Satisfied, yes.
I did something.
Okay,
right.
well, that's great. I mean, the whole point of this was, for you as an end user, it was a very human conversation to have, right? It's as if you're talking to another person on the other line, or at least that's what you strive to do. But in the meantime, you're able to collect extremely useful information about your user and even ask them about certain situations that they might be experiencing, thoughts that they might have, or even probably report on their community. Whatever that looks like. So what you can imagine is doing this 1 million times over for 1 million people on any given day, right? So this is what we do with U-Report, for example, in Nigeria. We ask extremely personal SMS-based questions to over 1 million young Nigerians. And every week, we're able to get some very useful information either to them or from them. And this is really powerful. And I'm sure Meaghan will continue reiterating this. This is not because of the tool per se, but it is definitely strengthened by a platform that enables you to do this. So then you can start building interesting programs that might even allow you to monitor stocks in over 16,000 clinics, as we do in Uganda. We're able to deliver HIV/AIDS results in a much more efficient manner, as we're doing in Zambia, so on and so forth. So we just wanted to give you a quick taste of what this tool is capable of doing in a very limited fashion. But then, what does real time mean in this case? We're not waiting 6 months to get all of those paper-based surveys into one place, put them into Excel, and do something with it. We can do that in a matter of seconds. So there's a lot of power in this tool. And what we intend to do is, over the next several months, as Meaghan starts engaging with your various sections, is trying to build out more capabilities so that it can support your program better. So I know this was a very short demo session, but if you have any questions around RapidPro, please feel free to contact me directly. And I will also be working directly with Meaghan to get a better understanding for your needs. Thanks.
Cool. So, Caduce, I'm just going to walk them through. I've logged into the health technical meeting, so I'm just going to walk them through quickly the last bit, and then we're open up for questions. So you can
Fantastic.
See...
And quick thing, Meaghan, also show them the analytics or the different responses that people had under analytics.
Awesome. Cool. So essentially what we built here, you can see it's kind of a grid function, so it's meant to guide you. It's what we call a flow. It's the same way that you think of a conversation. So if I were to introduce myself to you, there are certain questions in decision support that would take me to a different answer. If I ask you your hair color, you would tell me your hair color. If I ask you your favorite food, it's meant to work like that. So you can look at the different ways that you would want to guide the people that you're communicating with to give you feedback. And then within that, you provide validation. So validation just means parameters that allow the software to understand what you said and to interpret it. You found an error in our validation because when you said health, it took you back to the beginning. And that's one of the weaknesses. Well, it's one of the things that you can learn by testing the system. So you can see these were the questions that came to you. And then this is the point where it becomes a decision. If you say that you did enjoy it, then great to hear. If you say you didn't enjoy it, then we're really sorry. Can't do anything about that. But then how you can use this going forward is also within analytics. So analytics just tells you what people said back to you. These are a number of different systems that we've been testing and building, and this is us. So we asked questions around these 3 areas, and then it builds answers based on that response. So you can see there's a lot of different types of users in the room. We know all of your names, so we can also tell if we engage you across multiple fronts, the feedback that you're giving. And then in addition to that, we can tell what you thought. Wow. It's very vulnerable, but it's good. It's really, really good. So you could do this for health service outcomes, immunization. You can see that the sky is really the limit here. And then at the end of the day, you can start a new flow very easily. You just basically go back into a flow and create, and it's yours. Great. And so this is the tool that we're currently supporting as UNICEF. It's called RapidPro. It's cloud hosted. It can also be server hosted, so you can log into it locally. You can communicate via SMS, something called USSD, which is the timed interaction that can ask a number of different questions. And also IVR will be supported by the end of this year. So interactive voice response for low literacy populations. And then this also links up to other platforms. So the buzzword at the moment is interoperability. That's a fancy way of saying data can flow between different platforms. And there's interoperability that's been built between RapidPro and a tool called Iris, which is supported by IntraHealth and is a database for human resources in the health sector. And then also DHIS2 for reporting. So you can use this SMS-based interaction to gather feedback on reports. And then additional platform integration is planned. So now I'll let you guys ask questions.
I have a quick request. Thank you very much I personally enjoyed the presentation, very useful and helpful. You spoke about, you encouraged us to engage with you on the collaboration when we want to build something new. As you can imagine, we work with a lot of legacy and existing systems, and some of them, I would dare say many of them, have been designed without any consideration of users in mind. Yep. Yeah. So any thoughts for us how we can engage with you to right those wrongs?
Yeah, I mean, the first piece is to understand that tools are very personal. So you often have someone that's deployed a system. They're usually still within the Ministry of Health, and to say to them, I'm not going to use your system anymore, you're immediately a threat. So my recommendation for those types of engagements would be for us to work together and build out an evaluation framework that would allow us to assess the strengths and weaknesses, opportunities and threats within that specific tool, and then to look at functional requirements. So then to pull back after that evaluation and actually ask what we call blue skies questions around what is really needed now. Many systems that were designed, 20 years ago are based on paper, 5 years ago are based on SMS, and in the future could be based on a number of different types of infrastructure. As UNICEF, we work to provide for maximum scale, so that's why we still really believe that SMS is the most accessible form of communication. But to ask those questions and to not go in with an answer is usually the best starting point for what's ultimately challenging a legacy system. So, yeah. Yeah. Yeah.
And the second thing is, we also talked about
yeah.
particularly on the cloud based platform, part of it is about registration of pregnancy, and other discussions with people say, oh no, not registering pregnancy, all you adults and girls, and especially with where, for example, pregnancy
Yeah.
So how do you correct for that? So when I see them, so now we know all of the names.
Yeah.
That would be really scary for someone.
Yeah. Yeah, I'll start with the patient confidentiality question first. Within the workflow, so you can see within the presentation, back to the project Moana, the results actually are received by the clinic worker. So you have to, if there's confidentiality issues and there's an engagement point that's neutral and trusted, it often makes sense to have that be the touch point for all of your data. You still have the issue of having a mobile device that could be in a public arena that could be receiving information. There's the ability to create randomized user IDs and then to hold a paper log that matches those up. But what you've ultimately asked is a really, really deep design question that if it's not designed properly, ultimately does harm. And there may be communities where the best decision is not to register a woman for reminders and instead to say, I'm just going to give her a piece of paper. So you can also keep those options open. IVR is much more secure because you can protect, it's like you can set up a voicemail type of system that can have a level of login for that person to receive information. It's more expensive, but it's also seen as often highly effective. So if we had a specific program, I could draw you into some suggested conclusions. And then what I really like to do is not trust my own assumptions. So if we could, I would say to deploy 3 different types of models, maybe even just for a week, and just send them out, get information, get user feedback, and then design your system based on that experience rather than just thinking that someone might not like it. There's a lot of surprise when you actually put a system into a user's hands, how things can change. Yeah. So I don't know if I answered. Can you ask your first question again? I didn't get to write it down. Yeah, got it. Yeah, so we are deploying an Android application this year. So we will be in that space. Caduce is leading on that product development. So you will be able to engage, collect data, send information using an Android device. And it will also be more rich content. So things like photos or potentially recordings, different pieces of data that you would be interested to pull in. But it's still not there. So even in very advanced countries like Kenya, there was just a recent study that was released that said that 7% of women have access to an Android device nationally. That's not going to hit the bottom 20% of a target population. And even less likely is that you're going to have kids that are like kids here, that have their own mobiles. So if we're targeting and really trying to engage youth and trying to engage children, it's likely that they can borrow their mom's phone to send an SMS. It's unlikely that they can borrow their mom's phone to watch a video. And so it's thinking through what you really want to accomplish with that communication. But the tools will be there. So at the clinic level, I think that Android is the way forward. The level of complexity that you want to program with for pieces like ICCM and different evidence-based decision support protocols, you don't necessarily want to be doing that via SMS. It's very tedious. Yeah, you could. This is kind of a hub where the data sets could all live together. So you could have flows here, and all of the reports that are coming in can come from different types of users. Yeah, but it'd be great to engage. Like if anyone in the room is really interested in thinking around Android plus SMS plus USSD or voice, to help us to figure out what you would need in there. And I can see it's an abstract question to ask, but we would want to ground it in a program that you were really visioning an innovation component to. Please, yeah.
Thanks, Meaghan, for the wonderful presentation. Actually, I had the chance to work with this team.
Great.
And I've seen some, I mean, it's a really great experience that how we could really convert these, real-time data collection and convert it to analysis, and it really helps in decision making. That's the important thing. Just a couple of questions, like RapidPro that you are saying, is it for the community level people or for the health workers? Number two,
yeah.
I have, I mean, if it is for the community level people, how would you see the capacity building aspects for the bigger, larger scale? I mean, that's an issue.
Yeah.
And second thing is, how do you ensure the data validation? Like with the data entry, how do you know that it's correct or? And that thing we found it as a challenge.
Yeah. Yeah. So the first one, in terms of community level versus health worker, I'm going to answer your question with a question. What would you want the community level individual to gain from having access to RapidPro? If it was a community leader and you wanted them to just, be able to pull access to health facilities, and it's an 80-year-old Mazet, like an old man, then you probably don't want to spend a year teaching him how to use a computer. I've tried to teach my grandparents, they're 97, to use a computer for 7 years, and we've never gotten there. So you also need to look at the feasibility of that user actually advancing into the system that you're building for. That being said, if all you want to get out of the engagement from the community leaders level is the ability for them to feel empowered, you could also set up a flow for them to be able to send in surveys that they wanted to know from their target group. So you could have an entire flow for all of your 100 community leaders to send in questions, responses, then a central administrator could build the flows, and then you can send the results back to them. So there's ways that you can create access and use this as a hub for that access. Ultimately, this system is built to be simple enough that people with zero technical background, not programmers, not jargon speakers, not even app lovers, to be able to log in and begin to use it really easily. If you'd like a demo account and you want to start to use it, please let us know. You can do that even from today. This is a resource for the global UNICEF team to be able to engage with. The infrastructure to support that on a national level is something that needs to be set up. So this is a local number for the states, but it's not a global number, or it would be really expensive. And then the second question around data validation. We've designed RapidPro in such a way that you can't change the data that comes in. So as a presenter, I can't go in and modify your responses so that you all liked my survey or my presentation. We've done that very much on purpose. You can export data from the system and utilize it, but this should be your raw data. And then you validate it through another system like Excel.
My question is basically from the source. How do you validate the data, not at the administrator level?
Yeah. Then you
really have somebody called administrator who really control this thing, but at the source level, to help us that who we want to use.
You set up a list of possible responses. So you can control for, like, say that I wanted to know what your hair color was. I could say black, red, brown, and different spellings for those pieces will come up as valid responses. But I think it's going to be hard to answer your question thoroughly unless we were in a flow. But we could do that together, and I could show you that. Does that make sense? Yeah. A non-answer. Any other questions?
In general, I think that should be global. There's a lot of global collaboration.
Yeah.
And then UNICEF sometimes, when innovation is going, it's like not being part of the process all the time. That's happening with health. So we are very much involved in global collaborative monitoring, the data and so forth. So we want to make sure that we're not just like moving forward and doing things without, like, this is part, I guess, meeting with all of us, but without being, involved in what's actually happening in agreements that we're making. We're seeing it like not ignoring that and going forward and, so we have to kind of stop and go back sometimes and make sure that we're on. I like to hear, I like hearing that it's linked to IRS.
Yeah.
Linked to the THIS,
Yeah.
and so forth. I'm just making that general.
Yeah, that's really valuable. And also to know ideas from a functional space, like areas where you feel that we need to be part of certain dialogues or at least be dedicating resources to strengthening linkages. It's a good opportunity early days to flag those. My email address and Caduceus email addresses are just here. For Caduce. Let me just get this to be sent out. Sorry, my typing skills are horrible right now. Yeah, so just it's an open invitation to start the conversation. So I think if we could have those insights and document them, then that will help me to prioritize who it is that we're engaging with.
Can you talk a little more about the impact of Project One? And then also in general, are there case studies, written case studies available? Because a lot of the issues we encounter when we talk to our colleagues in the field is that, you know, for HIV, for example, we're really pushing the report, but we're constantly receiving all these skeptics, and we don't really have the publication information to back it up. Given that it is fairly new, so how do you address that?
There's a few case studies that have been published within the UNICEF team. So Project Moana is one. Also MTRAC for disease surveillance, it's disease surveillance plus stockouts. But a lot of it needs to be refreshed. That's the work that I'm doing in the first few months, is to build that out. Unfortunately, what I think you're going to hear, to be really transparent, is we don't know. Because right now, a number of the impact metrics that are being monitored from a donor perspective are number of users, number of messages sent. Very exciting, but doesn't tell you anything. And so that's why I'm trying to push all of our projects through a very different type of design engagement that will capture that at the beginning. And then when you go back to looking at the continuum, the 1,000 Days platform, it will be basically deciding as UNICEF, if you want to look at like use case one, creating a unique identifier, I'm going to have a laundry list of of the best practices indicators that you should be collecting to be confident of your evidence. And then I'll try to encourage you to tell you your data initially is going to really be bad. So there's also a curve with this type of behavior change program that it's likely going to take you 1 to 2 years, and nobody wants to hear that. But that's the reality. Yeah. But when we have those ready, I'll make sure that Maria and I are working closely together to get all of that out to your broader team as well. Yeah.
I was just curious about the principles that you laid out.
Yeah.
We all talk about what to do.
Yeah.
But not necessarily why we do it, and it's almost linked to the question around, the impact and success.
Yep.
Ready to link to why we do it.
Yeah.
It's exciting to have all these products, but at the end of the day, we want to live life, make children protected. We want to be different. So I don't see conformity, as a principle, answering the why question as opposed to this what to do.
Yeah, I mean, these are principles that design an intervention once you've decided the why. So it's a slightly different approach. These are global standards that have been agreed by the large donors and also groups like the WHO, and I don't think the World Bank has signed on. But it's essentially moving that next step once you've already asked the why. Still not complete, just as any 10-point edict is never complete. Yeah. And if your partners can't answer why, then you probably shouldn't be deploying something.
Yeah, because sometimes I wonder the reason why it doesn't work, like for some of the programs that
Yeah.
still there, is because the why question is exciting to them.
Yeah.
Emergency response, that was when people talk about the unborn system.
Yeah.
But I think the why was not really sort of explored. So
deep enough.
So it was exciting project.
Yeah.
It's still limited. So if people understand why we do what we're doing for,
yeah. Yeah. Cool. Any other pressing questions? Great. Well, thank you, everyone.
Thank you very much.
Thank you.